some of them have wounds that in previous conflicts they would never have survived. But they are horrible wounds. Again, they've lost limbs. Sometimes they have limb salvage, but they have lost massive amounts of soft tissue. They have a bone that will be very hard to make for a usable limb. And in some instances, we salvage the limb, and a year or so later, the soldier or the Marine will come back and say, you know, it's really not good for very much, and I think I could rehabilitate and be a lot better if we went ahead and did an amputation. And that's happening less now for a variety of reasons that aren't the subject of this talk. But that's so those are the young men and women that we're taking care of, the Walter Reeds and the Bethesdas and the Balboas and the Brooke Army Medical Centers of the world. And the conventional or traditional or normal or whatever medical techniques of taking care of these injuries simply do not suffice. They just haven't been enough. And so we have had to look outside of our usual comfort zone, which is kind of fairly orthodox medicine, to people like you to help us try to solve these problems. The rest of this talk is then to talk a little bit about how we're organized and how we do that and some of the things that we have going on. I would introduce here the fourth of the facts, and that is what we learned in a very painful way via the Washington Post and Walter Reed in 2007. And that was that the American people would not settle for conventional thinking. That for the young men and women who wear the nation's cloth and go to places like Iraq and Afghanistan and are exposed to improvised explosive devices that have wives and children that wait on them. And then when they're hurt, they go to our military treatment facilities and they hang in there for sometimes years as they're getting treated and rehabilitated. That America did not expect that we would be short-sighted or we would shortchange what we could offer them in any way, shape, or form. And so we had to, for one of the few times, look really outside our own area of expertise. And we did what we found sometimes in people who are probably in this room, and certainly across the country, we found a lot of people who said that they were willing to help. And so the rest of the talk is really about that part of the story. We like doing gap analyses. In the military, you get really good at doing gap analyses. And if you work in the federal government, doing gap analyses. And so when you look back at the first 2 or 3 years of conflict in Iraq and Afghanistan, these were the gaps. And these are fairly broad areas. Obviously, treatment of extremity injury, pain management remains an issue, rehabilitation. And we think pain management may relate somewhat to one of our big problems, which is post-traumatic stress disorder. We think more effective pain management early on may decrease the likelihood of post-traumatic stress disorder. So that's very, very important to us. Rehabilitation of neuromuscular injuries. Before these conflicts, we really didn't know very much about rehabilitation medicine. We relied extensively on the Veterans Health Administration to do that for us. We have had to learn a great deal about rehabilitation medicine in a very short period of time. Craniofacial injuries, some of the really tough patients we've taken care of have lost parts of their face, and that's very, very difficult for them to deal with and very, very difficult problem to treat. Burns and scars, there's a very good news story here in that the number of patients severely burned as a result of a conflict in Iraq and Afghanistan has dramatically declined over the years as we've improved the fire resistance of the clothing that they wear, and as we've continued to work on fire suppression systems inside their vehicles. Visual system regeneration, we don't have lots and lots of people who've been blinded as a result of Iraq and Afghanistan, and especially when they wear that eye armor that I showed you before. Orthotics, prosthetics, and robotics. Orthotics, I think, is probably the newest area where we have a tremendous amount of focus, and we're having to do a lot fewer of the delayed amputations, in part because of some of the successes with our orthotics. Besides treatment of visual loss, rehabilitation of visual loss is something we rely extensively on others. Auditory system regeneration. We have blown out a lot of eardrums in Iraq and Afghanistan, as you might imagine, from those IEDs. And certainly the treatment of traumatic brain injury. And regenerative medicine technologies have something to offer many of these areas, these gaps that we have yet to fill. This is